So, dear friends, Team Maha welcome you all for this 6th episode of Maha Case Challenge. This Team Maha idea to learn, to give some platform to all these office bearers and all academicians on Maha platform, and we have many experts in pediatric community who are always there for guiding us all, and this is a very nice initiative, and Dr. Pramod Kulkarni sir has taken over this Maha Case Challenge this time. Last year it was Dr. Mahesh Moite sir who put forth an idea, and there were almost 12 to 13 episodes of Maha Case Challenge. This time we have 2 cases, and Dr. Trupti Joshi from Aurangabad and Dr. Bela Verma ma'am from GMC Grand Medical College and Sir JJ Hospital, Mumbai. They both are presenters. And today we have two teams. First is from Dharashiv IIP and second is from Solapur IIP. And today's experts are Dr. Abhay Shah sir and Dr. Suhas Kulkarni sir from Kolhapur and Abhay Shah sir from Ahmedabad. So I welcome you all for this 6th episode of Maha Case Challenge. Today's guest of honor is Dr. Vasant Khaladkar sir, who is the candidate of President-elect post for 2024. He will be guiding us in this episode also. So today's moderators, Dr. Naresh Taide sir, and second moderator is Dr. Tripti Mahatme. So without wasting time, I ask Dr. Neha Singh to take us further in this episode. She is co-chairperson of Maharashtra IIP Women Committee. Over to you, Neha.
Thank you, Amol sir. Good evening to all the respected dignitaries, seniors, and my dear friends. I, Dr. Neha Singh, co-chairperson Maha Women's Committee and practicing pediatrician from Navi Mumbai, welcome you all for the 6th episode of Maha Case Challenge Season 2. Friends, as we know, this Case Challenge is a very unique concept program, and today we have Dr. Bela Verma and Dr. Trupti Joshi with their interesting cases to present with us for 2 branch teams, Team Dharashiv and Team Solapur, to crack the cases allotted to them. We also have Dr. Abhay Shah sir and Dr. Suhas Kulkarni sir as our experts for today. Now I request our Maha President as well as IIP Executive Board Member, respected Dr. Ramakant Patil sir, to please give his blessings. Over to you, sir.
Thank you, Neha. And we are back again for this most interesting Maha program of Maha Case Challenge. Friends, we have to challenge ourselves, and it's only the path for growth. And we face these challenges in OPD. Now, these are the attempts to reach to the hilt of the case, hilt of the situation. And we have got the ID expert luminary, Dr. Abhay Shah as an expert, Dr. Suhas Kulkarni. We are old friends from Kolhapur. Is also there. And HOD of Sir JJ Hospital Group, Dr. Bela Verma Madam is one of the expert and presenter, and Dr. Trupti Joshi is another presenter. And we have got Dr. Vasant Khaladkar as a guest of honor today. And this program of Case Challenge is being successful because of Dr. Pramod Kulkarni and ably supported by this Maha Case Challenge team, Dr. Neha, Dr. Anjali Gokarnu, Dr. Deepa Firke, Dr. Trupti, Dr. Ravindra Sonune, Dr. Vasant Khaladkar, Dr. from Aurangabad, who is also a vaccine immunologist, Dr. Khadke, yeah, and Dr. Naresh Taide, who is also expert today. And friends, we are all ears and eager to how this saga unfolds. And while this saga is being unfolded, the able team is there from Dharashiv, Dr. Birazdar, senior pediatrician, Dr. Prasad Dharma, Dr. Barathe, and also from Solapur, President Dr. Kundan Chopde, senior pediatrician Dr. Sheetal Gandhi, and Dr. Mitali Borgaonkar is there. And we just request for other delegates and viewers not to suggest in chat box or comment it, because we are curious and we know how it should be there. But being on the dais and being on the facing viva, because we all know what are the questions given to posed to others, we all know the answers. But whatever question posed to us, we many times do not know the answer. Similar thing happens even in case challenge. These are all able practitioners, all academicians. It is keeping the nerve and being in presence that will definitely unfold this saga. So with this small preamble, I hand it over back to Neha.
Thank you so much, sir. Uh, we have with us today. We have with us Dr. Rajendra Vasant Rao Kulkarni as our MMC observer for today's program. Sir is senior pediatrician from Nashik and also past TB member of Central IIP. Viewers, please note today's program has been allotted one MMC point. So requesting everyone to please type your name, city name, Central IIP and MMC registration number in the chat box. Now I request Dr. Pramod Kulkarni sir, the coordinator of Maha IP case challenge, to please give a briefing about the case challenge. Is this Amol sir?
I think sir is not there, so we'll proceed.
Okay. I'm extremely delighted. Okay. I'm extremely delighted to welcome our very own Vasant Khalatkar sir as our guest of honor. Sir is Director of Children's Hospital and Pediatric Infectious Diseases Center and Sir is Consultant Pediatrician and Neonatologist and Director of Colorado Children's Hospital of Pediatrics and Intensive Care Nagpur, National Chairperson Pediatric Infectious Diseases Chapter 2023. He is also National Chairperson Academy of Pediatric Neurology Chapter 2022-23. Now I request Vasant sir to please give his blessing.
Thank you everyone for inviting me am I audible?
Yeah, loud and clear.
Yes, sir. Yes.
Yeah. So thank you very much for Maha IP for inviting me as a guest of honor. And this is the 6th series which is going on well at rising heights and heights for everything. So I really want to appreciate the efforts of organizer. I will not take all the names. I want to welcome from Maharashtra Dr. Abhay Shah today, who is the expert. And we know about, everybody know about his expertise. He's known person in ID chapter. ID chapter में कुछ भी रहा तो अभय भाई की सेवा होता नहीं, इतना सब लोगों को मालूम है. He's one of the our key persons in ID chapter amongst 4-5 people. So he helped me a lot during my tenure as a ID chapter so much. And one should take the advantage of this chapter, and that's the work done by all our organizers. Dr. Bela Verma is Dr. Doshi is there. They are really it's fortune of us we getting the. I know Bela madam is very busy in spite of all that. They're taking time. Doshi madam also. So I want to again say hello to them. And before taking this cheats, that whether Solapur or Dharashiv, I want to request you. You all know Dr. Neha also said, Dr. Ramakant also said, I'm contesting for the post of National President this year, and I want to work with the principle that one is the integrity, that I want to integrate all the people from all over India, that with communication, with my friendship spirit, and through all these. And for academic, that academic really, without academic we can't go ahead. So we have seen in Maha IP, we are coming with the academic integrity, communication. Dr. Ramakant and Dr. Amol have made this communication so strong. This now Maharashtra IP reached a different height amongst all the states. And definitely progress. Progress is very important. I know with this integrity and academic, we can progress, but this progress is not possible without working of Yuva generation. And that we have seen today. We are seeing this. You see the screen. 70% are young, and because of these young people, this program is successful. So I want to take the advantage of these people and I want to promote them, your people. So working on the basis of integrity, academics, and progress for IIP, that is IIP. I want to work in future if I will be the president for the 25. So that is the elect president 24. So again, I request you all to kindly support me and you please work for me. And now, thank you. I want to take cheat, so it should be fair. So these are the two cheats are there, 1 and 2. So there is no bias. And now I will pick up one cheat. So this is the cheat. You're getting? This is Dhara. Yes. So I wish all the best to both the team, and I want to hand over to Neha for Dharashiv. Thank you.
Thank you so much, sir, for your words of wisdom. As team Dharaship will be our first challenger, and our guest of I would like to introduce our guest experts for today. Our first expert is Dr. Abhay Shah, sir, Director of Children's Hospital and Pediatric Infectious Diseases Center, Ahmedabad. Sir was National Scientific Convener, IIP Action Plan 2020-21, Executive Board Member, Central IIP 2009, 2012, and 2018, Chairperson, Infectious Diseases, IIP Chapter 2015. We also have with us Dr. Suhas Kulkarni, sir. Sir is Professor, Department of Pediatrics, D.Y. Patil Medical College, Kolhapur. Sir has been teacher there for last 15 years. Sir has 15 publications, and sir is has completed international course of bioethics. He has advanced course in medical education for Nodal Center, and he is member of Institutional Research Review Committee, IRC, D.Y. Patil Medical College. I welcome both of you, sir.
Thank you.
Now I request and hand over to Dr. Naresh Yade, sir, our Zonal Coordinator of Case Challenge, to please introduce our first presenter, Dr. Trupti Joshi ma'am, and the further proceedings. Over to you, sir.
Naresh sir, please unmute.
Yeah. Good evening, everyone. Welcome to Maha Case Challenge 6th in the series. And our today's presenter is Dr. Trupti Joshi Madam, who had Associate Professor at Department of Pediatrics, Government College, Medical College, Aurangabad. Madam has academic experience of 14 years. And Madam, as a researcher, they have done as a PG thesis, guys, ICMR short-term project. There are many national and international publication in Madam's credit. And I welcome Dr. Trupti Joshi Madam, who is going to present the case to Team Dharashiv. And in Team Dharashiv, we had members Dr. N.D. Virazdar sir, Dr. Prasad Dharma, and Dr. Markanda Barate sir. Welcome everyone. I request Madam to please present the case.
Yeah. Good evening, sir. Thank you for the short introduction.
One
Share
minute,
my screen.
One minute, Dr. Trupti, 1 minute.
Yes, sir.
Dr. Amol, what is my role?
Yes, sir.
I'm just attending for the first time, sorry.
Okay, sorry, sir. I will tell you, you are today's expert and the presenter will be presenting the case stepwise. He will, she will be revealing the case and then she will ask the team participants some questions related to pertinent to this case. And then with some inputs, also these teams will be cracking the case. So in between, if you feel so that something is some
Acha.
expert advice is required, then you can intervene in between, and then at the last 15 minutes, you yourself and Suhas Kulkarni sir will be guiding both the presenters and this
Okay.
team participants.
Okay, got it. Yeah, okay. Please go ahead.
Abhay sir,
Yeah.
you have to assess the case and
Yeah.
what are the question out of box, or as an ID expert, you have to give your some opinion also. Because
Okay.
whatever they have not covered, you
Okay.
cannot tell the people so that everything should get covered. Basic purpose of your expert is everything, all the everything should be covered, those which are left out.
Got it. Yeah. Okay. Please go ahead.
Thank you.
Yeah. Okay. Thank you.
Yes,
Yeah.
Trupti ma'am, please start.
Trupti ma'am, please share your slides. And each case will be given 30 minutes to present, and rest 15 minutes is for discussion as well as expert opinion. So total 45 minutes we have.
My screen is visible.
Yeah.
Yes, ma'am.
Yes.
So, good evening, everyone. As already introduced, I am Associate Professor at Government Medical College, Aurangabad, and I thank organizers for giving me this opportunity to present a case in Maha AP Case Challenge. So, I will start with the case. So, we had a female child who was 10 years old, second by birth order, born by non-consanguineous marriage, residing near Aurangabad, that is Haldar, Hindu by religion, and was brought by mother in November with complaints of, there were 3 chief complaints. First was swelling and pain over left leg since 45 days. Initially, the swelling appeared. Then gradually it was an insidious onset thing. Then the pain appeared, and since last 3-4 days before admission, that is on 22nd of November, the pain was excruciating, and that was the reason the patient visited hospital. Second complaint was complaint of dull, aching, generalized abdominal pain, which was there for 15 days before admission. There was complaints of decreased appetite. And she also had complaint of fever, which was mild to moderate grade since 2 weeks. So with these chief complaints, the patient presented to us. So before we proceed further, for all the pediatricians who are there for the challenge, I would like you to give your inputs regarding few probable differentials which you may think after this initial chief complaints and whatever I have elaborated about the complaints.
Actually, I want to know the swelling of and pain over the left leg. Exactly what location pain is there?
Yeah, it was generalized all over the limb. Initially, it was in the edema which mother noticed and the child noticed was over the foot. And then gradually it had increased and it was up to the thigh. And then she had severe pain over there with swelling of the whole leg, which started from the foot.
Okay. It's aggravated during day or night?
Actually, there was no aggravating or relieving factor, but the pain which had increased was like she was not able to move. Normally she used to go to washroom on her own, but since last 2-3 days it was so painful that she was not able to move also.
Is limping during walking since 45 days or only from 3 days?
This complaint of not ambulation was only since 2 days, maybe 48 hours or so. But before that, she was ambulatory, but pain and swelling were there, for which they had taken some treatment from other doctors. But because a mother was not that anxious about the child, and she thought that this will resolve, so they did not pay attention to it.
There is redness over the skin, or it's normal color of the skin?
Yeah, there was redness over the skin.
Warmness?
Yeah, it was warm. We will come to the examination further.
Okay.
Yeah.
Okay. Madam, I would just want to ask any history of any injectables, intramuscular injections?
No history of intramuscular injections given.
Okay.
at that site or anywhere. Yeah.
Actually, this child presented with left leg pain. With
Yeah.
swelling.
But
It is
other complaints were also there. Abdominal pain was also there. Appetite was also reduced and fever was also there associated with it.
What is the duration of fever?
What I did not get. What
Duration of fever?
duration? It was since 2 weeks, 13 days before admission.
Actually, I want to first analyze the swelling and swelling of the leg, because there is a tenderness there, there is pain is there, there is
Okay.
redness over the skin is there,
Yeah.
and third is there is a pain in the left leg also there.
Yeah. So
this
before
swelling
that,
looks
would you
like,
be interested in getting more
Because
history
first-
about the patient?
what about?
About more history about the patient before you go for examination?
Any other
Yeah,
joint
so
pain?
I'll just tell you.
Joint pain,
Yeah,
any
so
joint pain
we,
on other legs and other.
yeah, there was no
arms.
swelling. Yeah.
Yeah.
So what we thought of and what histories did we ask? I will just go ahead.
Yeah.
Okay.
So there was no history of trauma, which was important for this. There was no vomiting and burning micturition because she had fever for so long. No high colored urine or jaundice. There were no acute abdominal episodes of pain, no seizures, and no history of chronic cough or breathlessness with this complaint of fever for so long. And as we know that the treatment details were not available, they took treatment from a local doctor. So that suggests that it was a chronic thing which is there since last 1 month, 1.5 months before the child came to us. So just
Any history of hematuria?
no history of hematuria.
Oh,
This swelling looks like chronic inflammatory swelling. Because
Yeah,
child
it is
has
the inflammatory
chronic
swelling.
Chronic inflammatory, because
Yeah.
duration is 45 days.
Yeah.
It's not acute. So,
Yeah, but it increased acutely since 2 days before she presented to us.
yes.
Okay,
So,
I'll-
so 1 minute. So there is an acute exacerbation of the chronic condition. That is one that is derived.
Yes. This is
Number one.
acute or chronic presentation.
Yeah. Number two, there is a diffuse swelling which was not bothering too much, and the child was totally ambulatory. And last 2 or 3 days, something has gone wrong. So I would like to ask anybody, which are the conditions of the swelling which lasts so long?
So, sir, first I analyze from the bone, soft tissue, and skin. With this chronic interstitial spaces, it is chronic inflammatory edematous swelling also may be there. Chronic inflammatory edema can cause this swelling. Second thing, if there is a vascular blockage
yes,
at
yes.
the
It is
abdominal level.
Yeah.
venous engorgement.
Yeah.
It can be venous engorgement.
Yes, it's vascular blockage at
Yes.
abdominal level, because swelling all over the left limb.
Yes.
It can possible to blockage of the venous return, that is venous
Yes.
blockage or arterial mainly venous blockage.
Yeah.
Can
Yes,
leads
yes.
to the edematous of the edema of the leg, and that swelling should be the painful. So third will be the lymphatic vessels. That is
Yes.
our area, some part of the area. There is filariasis is the common.
Yeah.
In filariasis also there is swelling of the single leg with the painful swelling. In the if there is infection, initially there is no pain. First is the venous, then there is second is the lymphatic. Third, generalized swelling should be from any bony or any soft tissue involvement should be there, maybe there.
Yeah.
And the recent onset of the fever, it can be due to the secondary infection. That is the secondary skin infection due to the swelling of the left leg.
Yeah.
Secondary skin infection.
Yeah.
Okay. So can we move ahead?
Yes,
Yeah,
yes, madam. Yes.
Yeah. So with these complaints, we thought of many differentials, right? We thought that she might had, there was no history of trauma. So fracture, other soft tissue injury was out of question. We also thought about it, is it osteomyelitis? or scurvy or osteosarcoma, we don't know.
But in scurvy, there should be the bilateral other.
Yeah,
so only
yeah,
single
other
leg
terms.
involved.
Yeah. So this is
Ah.
what was the thought process going on with just the presentation, right?
Yes.
Was it enteric fever? We don't know. But it was not like fever was not step ladder sort of fever, and history of anorexia was there.
But why there is swelling of the only
Yeah,
one leg?
that
in the
swelling is
enteric
not
fever?
explained. Yeah, definitely. There is no vomiting or burning micturition, thinking of UTI, appendicitis. Here also the swelling of the lower limb is not explained.
explainable.
Yeah, hepatitis also does not explain. Acute intermittent porphyria, but there was no seizures or acute abdominal episodes. It was not explained. So we thought that it is something chronic, and it has involved, as you have said, that there was something wrong with the venous system or lymphatic involvement, right?
First thing is that it's chronic. Second thing, it may be inflammatory. It should be it may be the inflammatory swelling.
Yes, that is what we also thought when we were treating the patient. So when we
so when there is a unilateral swelling is there, it will mostly rule out systemic causes. It will mostly rule out your edema because of the malnutrition. It will rule out your scurvy, right? Number one.
Yes.
There is no history of trauma, so traumatic local injury is also left.
Yes.
So
But
now
malnutrition is also the bilateral should be swelling.
I told it rules out malnutrition.
Rules out.
So important thing that it can be a cellulitis, chronic cellulitis. Of course, it is less possible, but it can be chronitis. Someone rightly raised because the child is having a fever. So we have to think of the inflammation, which may be infective or non-infective. Among the infective, it can be a cellulitis. It can be necrotizing fasciitis, right? It can be a deep-seated some occult collection which cannot be revealed. Number 3. And number 4, it can be a phyllosis, right?
Yes.
And if you look at the pain in abdomen, out of all these 4 conditions will not explain why the child has got the pain in the abdomen. So it will explain a fever. It will explain. Please let me finish. So it will explain fever and your localized, generalized swelling of the one limb, but it will not explain the pain in abdomen. Now we have to incorporate the abdominal pain as well in this symptomatology. So now what is the thought process?
So sometimes there may be the abscess in the pelvic area.
Yeah, exactly.
It can cause vasculitis.
Yeah.
That leads to some obstruction of the vessels, can lead to the swelling of the left leg.
Or sometimes some lymphatic vessel involvement, which is also there in the abdomen as well as in the periphery.
Lymphatic as well as vascular.
Yeah.
Okay. So we move ahead with the case with further history. So past history was not significant, no similar complaint in the past. Family history was significant, where father had history of tuberculosis, which was 4 years back. And he died 4 years back, and he had taken treatment for 2 months. Birth history was not contributing to the patient's condition. Immunization was complete and BCG scar was present. Developmentally, the child was normal, and they hailed from lower class according to modified Kupuswamy scale.
There is history of the tuberculosis in the father. So sometimes there may be the pot spine or abscess collection at the psoas area or the left psoas abscess can be possible. That leads to the vasculitis, which leads to the swelling of the left leg. Because father having tuberculosis, so can possible there may be the involvement of the spine or abscess at the psoas area or in the left iliac fossa can be possible this presentation also in this case.
Okay, but actually, it is possible, but
one
the
of the
was like 4 years back. So if we define a Cox contact, so she does not come under the definition for Cox contact.
TB calendar, it's not fit in the TB calendar.
Yeah, typical case, right?
Okay.
So we took her anthropometry. Her weight was 19 kg. She was 10 years old. Her height was 124 centimeters and BMI was 12.3 with a head circumference of 50. So we plotted it on the BMI chart, and we saw that she was falling below the third
centile, yes.
Yeah.
Weight is not appropriate.
Weight was also low for her age. That Yeah.
That is chronic wasting.
Chronic, yeah, this
Yeah,
suggests of a chronic disease.
this disease should be the chronic disease. It
And
leads to the
right.
chronic wasting of this child.
Yes. So should we move ahead?
Yes,
ma'am,
yes.
Okay. So vitals on admission, when she got admitted to us, when we examined her, she was not having fever. Then also her pulse rate was 92 per minute. Respiratory was 24 per minute. Blood pressure was normal. Saturations were normal, and her peripheral pulses were well felt.
Okay.
Okay. And moving ahead on examination, she was malnourished. She had pallor. There was no lymphadenopathy. On local examination, swelling and tenderness over left leg and Moss's sign was positive. On systemic examination, there was generalized tenderness more over the umbilical region, no organomegaly. Her CVS was normal, CNS was absolutely normal, respiratory system was also apparently normal. So, do you want to ask anything else? Or should I move ahead?
Yes, there is warmness is there or not?
Yes, sir. Moses' sign was also positive. So actually, should I elaborate on Moses' sign?
Yes.
Yeah. So when we place the child in prone position and flex at the knee joint or the left leg, and then give compression over the calf muscles, there is pain, and that is a positive sign, and it is suggestive of venous test.
DVT.
Yeah.
DVT.
Yeah. It is most probably positive in DVT.
DVT.
Yeah. Okay, should we move ahead?
Yes.
Is there any guarding or something on poor abdomen examination?
No, there
Any
was no
related?
guarding. She was allowing examination, but mild
Okay.
tenderness was there.
Okay.
So with all this, what do you think? What is your clinical diagnosis, and can we have some idea about some differentials?
Definitely, it looks like the venous blockage.
Yes.
So you have to see
secondary to any lump or any
abscess in the
any
abdomen.
cold abscess. Yes. In the
Because-
pelvic region, most probably.
Okay.
Because this condition is a chronic. So it is chronic illness.
Right.
So it should be the tuberculous cold abscesses can at the left iliac or psoas area. Leads
Okay.
to the vasculitis, which leads
Right.
to the DVT, deep vein thrombosis. This
Right.
may be the possibility in this case.
Yeah. Any other
And
possibility can you
second,
think of?
Yeah.
Yeah. Should I continue?
Yes.
Yeah. And the second possibility should be chronic and on acute. So it's edematous leg. After that, it causes secondary infection, like
Right.
it can be lymphatic infection can lead to the painful leg because chronic on acute, that is history more painful since 3 days.
Right.
So it may possible chronic edema of that leg and with secondary infections.
Right.
Yeah.
Since madam, there is a Moses sign is positive and it indicative of deep venous thrombosis.
Right.
We should also think of any APLA-like conditions, because since she's an adolescent female and
Yes.
she's having wasting and stunting,
Yes.
so something is more than just that is this. What is this total whole
Yes.
presentation? Something is really back to the stage that is
Yes.
giving rise to all these symptoms.
Correct.
You have to rule out the causes of DVT. That is,
Yes.
lead and factor 5, protein C deficiency, protein S deficiency, and third thing is
APLA.
APLA. From the yes, APLA. You lipid antiphospholipid antibodies. You have to rule out that causes
Yes.
of the deep vein thrombosis.
Yeah.
Yeah.
Yes. So actually, I am presenting the case as we saw the case, right?
Yeah.
So you may get some surprises in future. So this is what the patient presented, and we thought of all these differential diagnoses. But as we are working in a government medical college, so all investigations are not possible. Even if we think of doing it, the mother was also not affording. She was the only parent for the child. So all these investigations were not possible at our end. Right.
Yes, ma'am.
So let us move ahead. So we did investigations which were possible at our side, and we saw that she had anemia. Her HB was 9.3. TLC was on the higher side with all this fever and cellulitis thing with polymorphonuclear predominance. Platelets were 4.6 lakhs. Urine routine microscopy was within normal limits. Her KFTs, LFTs were normal, right? We did her PTINR also. So these are the reports.
So any input?
That count is high, so it
Hmm.
may be the secondary infection is
Hmm.
there. Count is
Yeah.
20,000 with polymorphic predominant.
Right.
ESR is not there, madam.
Yeah, ESR was 40. Sorry, I forgot to write it over
Yes.
there. Yeah, it
Yes,
was 40.
yes.
Yeah.
Okay.
Yeah. CRP, you are done in CRP.
CRP, we have qualitative, it was positive.
Okay, not
We don't
quantitative.
have quantitative available at our side.
Okay.
So should I move ahead?
Yes, yes.
Yeah.
Madam,
Secondly, you can see that there is neutrophilia with polypredominance. At the same time, there is thrombocytosis as well.
Yes.
So, of course, it can be infection, but at the same time, it can be inflammatory response as well. And it can be inflammatory superadded with infection also. The thrombocytosis, we should to be considered a little in a different direction. Yeah.
Right.
I want to know what is MCV in this child, because I want to know it is
Yeah,
iron
that
deficiency
is a
anemia.
problem
or
at our side. We don't get MCV, sir.
next cell
Actually,
filter.
yeah.
Okay, one more thing is about PTINR. Can you say it is normal?
yes.
What is PT? Test and what is control?
Yeah. So actually,
want to know
what
the test
happens?
and
Yeah,
control.
yeah. What happens is with these reports, we cannot rely upon these reports because we send them late. The reports reach us also late. So just depending on these reports, it becomes very difficult to interpret anything. So looking at it, we did not pay attention to it, this report at the initial go.
Okay. Okay.
So should I move ahead?
Yes.
ma'am.
Yes.
Okay. So with all these things, so we thought that her abdominal pain is also there. We have to do some radiological investigations also because these
yes.
were the initial blood investigations which we did. So we went ahead with the radiological investigations. So what radiological investigations would you suggest for this child?
I want to know Doppler of the
USG.
vascular Doppler and USG abdomen.
USG
Right.
abdomen and Doppler.
Doppler
Yes,
of the vascular.
yes. We did everything. We did X-ray chest, which was normal, and we did USG abdomen and pelvis, and which was suggestive of terminal ileum thickening of 5.8 millimeter with multiple subcentric lymph nodes in right iliac fossa and right lumbar region, and few of them were conglomerated. And color flow imaging of left lower limb showed echogenic content in left external iliac vein, which was extending up to proximal 1/3 of femoral vein, showing no vascularity on Doppler study, which was suggestive of thrombus, and changes of cellulitis were there over entire lower limb.
Yeah.
Okay, should we move ahead?
Yes.
Sir, one comment should be there. In terminal ileum, the tuberculosis of the intestine, most of the time, the part of involved is the ileum, that is terminal ileum. So I want to some stress on that sonography report because child in reporting there is terminal ileum thickening, significant thickening, that is 5.8 millimeter.
Yes.
So I want to stress also on tuberculosis. Tuberculosis leads to vasculitis also.
Yes.
Sometimes. Can the tuberculosis leads to this vasculitis?
It can lead to
And
vasculitis.
it is a it is a triggering factor for
Hmm.
immunological phenomena, not the direct invasion by
Right.
tuberculosis, and that
Yeah.
it is a triggering factor for the thrombosis.
Okay.
Yeah.
Right. So it was a possibility for this case.
Yes.
Yes, definitely. So for that purpose, we again went ahead, and this I have already said, it is again, it was done. Serology was negative. We thought of doing serology also. Gastric lavage, CB-NAT was negative. MTB was not detected. Then one event happened with the child. So she was there with us for 10 days, and we were just thinking of the differentials and trying to get all these things investigation. You know, at government medical college, the things, they move slowly. So it was almost 10th day when we did all these things, and one fine day, on the 10th day, she threw seizures. So she had generalized convulsions, which were initially focal, which generalized later with high-grade fever. And she needed to shift to PICU at that point of time.
Yes.
Yeah. So any comments about her convulsions?
Keeping in the mind the wasting, stunting of the patient, disease is so much chronic, and disease is also involving the multi-system, and then the patient is throwing the convulsion. It can, one possibility, there is father history of, though the history is very old, the history of pox in father, TBM is one possibility we should keep in mind.
Okay.
Second thing is child having high-grade fever. Sometimes fever is a trigger factor for the convulsion.
Right.
This may be the second possibility.
Yes.
Tuberculosis definitely, because child having multi-system involvement, that is a vascular involvement, intestine, GI involvement, and third should be the CNS involvement.
Yes.
This may be the
Yes.
possibility.
There is a CBC picture.
Yeah, actually we did CBC again, and it was again, the TLC was on the higher side. It was polymorphonuclear predominance. Similar reports we had. We repeated it 2 times, once after 5 days of her admission and one when she had this event.
I want to know, after convulsion, child is better or going to the comatose or sleepy or drowsy?
Yeah, she
immediately.
was drowsy. Yeah, she was drowsy, and we required her to shift her to PICU. She was drowsy for almost half an hour after her seizure.
After half hour, he's gained conscious.
She gained conscious. Yeah,
Then
her consciousness was, she regained her consciousness.
There is a possibility of tuberculosis involvement is less.
Less likely.
Less likely, because there is convulsion after TBM or any tuberculosis in the brain.
Sensorium deteriorates.
Sensorium deteriorates.
And
it doesn't improve within half hour.
Right.
Yes.
Yeah. It may be fever triggered convulsion.
Yeah.
Seizure. Fever triggered seizure. Sorry.
Yes. Yes. So for
how
her,
was the electrolytes and sugar at this during the convulsive phase? Sugar, electrolytes, everything was done?
Yeah, electrolytes were done. Electrolytes were within normal limits at that point of time. Her sugar was also normal. And then we thought of going for a lumbar puncture, but mother did not allow us to go for a lumbar puncture for this child.
Are you doing any neuroimaging?
Yes, then we went for a neuroimaging, and I hope this will help you.
Yes.
So we went for a NCCT brain. It was suggestive of 1.5 by 1.6 by 1.6 size, well-defined heterodense lesion with surrounding perilesional edema in left parietal lesion with mild compression of ipsilateral lateral ventricle, suggestive of a space-occupying lesion, which was not leading to a shift of the midline.
It most likely looks like a tuberculoma.
Right. So this is
what
convulsion
is, madam. I want to ask that convulsion is a focal or generalized?
Initially it was focal, and initially it was focal followed by generalization.
Yes, you have to give history first, this only, because
I told actually, actually it is not written over there, but when I elaborated the history,
it is focal, then it's fever triggered seizure is less likely, because focal you have to rule out the space occupying lesion.
Yes.
Yeah.
And this was the clue, and we were at that, and we proved it with an MRI also, and again MRI showed similar lesion in the parietal lobe with the surrounding white matter edema. Similar reports, but MRS also showed lipid lactate peak. So any comments about on this?
Lipid lactate, Mycobacterium having
Yes.
lipid.
It has very
Mycobacterium
high
has
lipid content.
High lipid. So it's
Yes,
lipid
their cell
like
wall
the
has a high
tuberculosis.
lipid content, and
Yes.
anaerobic conditions lead to lactate rise.
Yes,
So
possibly
MRS
present.
also showed the peak, and we know that this is a tuberculoma, right?
Yes.
Now, yes. So final diagnosis?
It's first is tuberculoma in the CNS. Secondly, there is GI involvement because there is terminal ileum thickness, and third is a vasculitis because of the tuberculosis that leads to the deep thrombosis. It's mostly because of the only tuberculosis.
Yeah. So what is your diagnosis? So do you
Tuberculosis.
want to stay at only tuberculosis? Would you like to
Most
add on?
probably tuberculosis.
Most probably tuberculosis leading lies to secondary APLA or any prothrombosis state.
Yeah, that is a possibility. We did not have those investigations. Otherwise, we would have proved that.
Tuberculosis is known to cause the vasculitis. Yeah. Investigation to rule out tuberculosis, you have to do other investigation also.
Yeah, it was not possible. Actually, interferon, all those things are not possible.
You have to do CT guided biopsy of that lymph nodes.
Yeah.
You are doing any CT abdomen to see any lymph node or any necrotizing central necrotization.
Yeah. CT abdomen is available at our site.
Have you done that?
Yeah, it was done, and it was again suggestive of the similar findings which we had on the USG. It was suggestive of necrotizing lymph nodes, conglomerated lymph nodes.
Central necrotic.
Central.
This is suggestive of tuberculosis only.
So
but
for tuberculosis, would you like to elaborate the type of tuberculosis?
For diagnosis, you have to do biopsy of that lymph node.
Yes.
CT scan is not the diagnostic of tuberculosis.
Correct.
Yeah, but there is no facility in your center.
So there are what type of
what type?
What is in addition tuberculosis? What is the type of tuberculosis? That is important.
Yes.
What type? What system or what type?
What type?
What type?
Okay.
Can be a tuberculosis.
So should I go ahead?
I don't know classification.
So when more than two and more than two systems are involved, it is a disseminated tuberculosis, right? Yeah, so it was a disseminated tuberculosis.
Okay.
And maybe this is not the part of our case challenge you wanted to diagnose. So with whatever limitations at our setup, we were able to diagnose a disseminated tuberculosis, and this is what the treatment was done. Initially, we started her on antibiotics for first few days till we got all the things. Then we started her on antitubercular treatment. For her seizures, anti-epileptics were given. We also started her on steroids as it was a disseminated tuberculosis, and she was given low molecular weight heparin in the initial period where we were monitoring her PT-INR regularly. So this is what the treatment was given. And just to elaborate the learning points which we had from this case, so tuberculosis, the mechanisms for venous thrombosis in tuberculosis, it is very rare in children. We see vasculitis, but venous thrombosis in children is a very rare phenomena. There are very few case reports which are reported in children. In adults, it has been reported. So these are few mechanisms which lead to venous thrombosis. Even after starting the treatment also, it leads to hypercoagulability by killing mycobacteria, and it may lead to the inflammatory cascade and may lead to venous thrombosis, one of the mechanisms, but it was not there in our case. So we had thrombocytosis, and maybe that this is the reason for which, and again she had abdominal cocks, right? So there are few case reports which have been reported.
Madam, I want to point out most commonly in tuberculosis, arterial involvement, that is aorta arteritis is there. It's very rare venous involvement.
Yes, very rare.
Arteritis is much more common than the venous.
Yes. So we also did her angiography, which was normal.
Okay.
Yes, okay.
Yeah. So as we see, there are two case reports. After literature search, we found that one of the cases, it was after starting AKT, and in the other case, the child had similar presentation as our case.
Okay.
So we all know about the management of tuberculosis. Yeah, thank you.
Thank you, madam.
Yes.
Okay.
Excellent presentation by Dr. Trupti Joshi ma'am, and rightly case was decoded by the team. Team. So we congratulate both of them. I request our expert, respected Dr. Abhay Shah sir, to have their comment, please.
Yeah, so excellent case, Dr. Trupti, and very well rightly decoded and opened the Pandora's book by both the panelists. So that is congratulations to all the three. Now, one important thing, madam, I would it would have been better if you have shown the picture of that cellulitis, number one.
Yes, yes, yes.
Now, number two, now, so history was totally from the chronic. So
Yes.
almost we ruled out that any infection would not go so long, except
Right.
tuberculosis, brucella, and deep-seated abscess. Number three. So these three things are very important. Now, the child was having a chronic malnutrition, that some stunting was there, pallor is there, and from the first clinical exam, we found that there is a deep vein thrombosis was there. So
Yes.
some
Yes.
venous occlusion was there.
Yes.
Right now, there was involvement of the abdomen as well as the lower limb. So something
Yes,
was cooking in the abdomen, which was giving rise to pressure symptom to the peripheral limb. That was the very thing. Now, lot of things have come up in your examination. So there was thickening of the terminal limb.
Yes.
The lymph nodes were where they were conglomerated.
Yes.
So
Yes.
most of the time we see that the non-specific lymph headache, but there are certain lymph nodes. A good sonologist can pick it up. That is conglomeration, adherence, pulling of the surrounding structures, distortion of the IC angle, and central necrosis, and the fluid around that particular lymph node. If these 4 or 5 things are there, I think they're highly suggestive of tuberculosis.
Yes.
So if facility would have been there, I would have definitely go for the lymph node biopsy,
Yes.
maybe CT guided, or I would have gone for the colonoscopy and to have a punch biopsy from the ileocerebral junction. Number 2. Number 3, there has been an involvement of the CNS. As rightly mentioned, there is hematogenous spread. So it's a case of disseminated TB. But the HIV is negative, but at the same time, this child should have actually go for the TB culture.
Yes, yes.
It's a lucky that it's a drug sensitive TB. Many of such cases are even
Maybe
drug resistant. Many
yes.
of these cases unnecessarily get empirical AKT without any diagnosis. So these are a number 3. Sometimes T cell defect can have this sort of dissemination.
Yes, sir.
And as rightly mentioned, the vascularity is there, but it is mainly in the form of arterial form, not in the venous form. And when you say of the TB tuberculoma, you remember the size. Even sometimes this spectrometry may not be available, lipid spec not there, but you can see the size. This large size cannot be there in NCC. It can be only in tuberculoma. So the size, the location of the space of a lesion was highly severe tuberculosis. The USG finding in the ileocecal region were highly severe tuberculosis. Your chronic history, malnutrition, all. So in our country, what more we need to diagnose TB?
Yes.
So an excellent case, and
Thank
all
you,
the
sir.
experts have decoded it very rightly, and you presented very nicely.
Thank you, sir.
So thank you for this opportunity to me as well. Yeah.
Thank you, sir.
Dr.
For
Suhas,
your
you can have a comment. Yeah.
Yeah.
comment. I request Dr. Suhas sir to have their comment, please.
Yeah, sir has already elaborated most of the points, but at the same time, there are a few points against from initial point of view, like fever, then leukocytosis, and all those things. So that was the thing have to be answered, and usually you get them when the patient gets dissemination, and that time only you can have such high fever or that cellulitis we were saying. So could be that also, because you already started the antibiotics also. So sometimes such swellings, even though there is a venous thrombosis, patient may have secondary infections also sometimes. That also has to be taken into account. And so it was nicely decoded. So right from, so these were things which are against, but in spite of that, they stick to the tuberculosis till end. So I congratulate them again. Thank you.
And one more point, sometimes, of course, the tuberculosis was very highly, but sometimes the child is not malnourished. The similar type of the MRSA occult abscess can occur, and this MRSA can also be the vein, local venous thrombosis and present in a similar way, right? So it is number one. And second, madam, you said about that because the disseminated tuberculosis, we started steroid. I think just to be on a caution side and as a recommendation, it is not the disseminated because the neurotuberculosis that warrants the use of steroid.
Oh, yes, sir. Yes.
So the child is disseminated TB but no CNS enrollment or no pericarditis, we will not give steroid.
Okay, sir. Yes, yes. Point taken, sir. Yes. Thank you.
Okay. We can move to second case if organizers are ready. Yeah.
Yes, sir. Excellent presentation and decoding. Now we are going for the next interesting case, which is going to be presented by respected Dr. Bela Verma, ma'am. Madam's slide, please. Introduction slide.
Neha, are you there?
I will read out. Okay.
Yeah.
Yes, sir. Actually, I think so. There's some problem with Zoom.
Okay, no issue. Dr. Bela Verma, madam has professor and head of Department of KM Hospital. Madam has major achievement.
I'm at JJ.
JJ.
Okay.
JJ,
Sorry.
Grand Medical College.
Sorry, ma'am. Madam has Department of and head at the JJ Hospital, Grand Government Medical College, Mumbai. Madam has National IAPB member in 2022, and Madam also had received fellowship of Indian Academy of Pediatrics. Madam has member of different subchapters and chapter of IAP IAP subspecialty. Also had one important is Madam as a national faculty for NTP, NCECD, and 24/7 common problem in pediatric practice. Madam has past president of Indian Academy of Pediatrics Mumbai branch in 2018 and 19. And Madam has 19 international and 17 national publication, one book chapter for their credit. I welcome Madam, and Madam is going to present their case to team Solapur. I request Madam to introduce their team.
I'm supposed to do it?
Ma'am, I'll just read out the names. No problem, ma'am. So I invite team Solapur for the further challenge, which will be the case which will be presented by Dr. Bela Verma, ma'am. So I invite Dr. Sheetal Gandhi, Dr. Kundan Chopre, and Dr. Mitali Gurgaonkar to decode the further session. And I request Bela Verma, madam, to please start up with the case. I hope all the three challengers are there.
Yes, ma'am.
Yes, ma'am. Ma'am, please go ahead.
Ma'am, please go to the first slide. Please.
So this is a short case actually, but the story went on long because the child was admitted with us twice and all. It was almost for a month every time. So it is a small short case, but nevertheless a very important and an interesting one. So this was a 13-month-old female child, Muslim by religion, first issue of a non-consanguineous marriage. So the only issue when she presented with a weight of 4.6, admitted in September last year, and she was with us for more than a month. Her weight was only 4.6 kgs, and she was admitted with history of loose watery stools without any blood mucus for 3 days, fever and fast breathing for 1 day. On examination, she was febrile with tachypnea, intercostal, subcostal recession, tachycardia. Her BP was low. Her SpO2 on room air was 94%. There were signs of severe dehydration, cold extremities, severe pallor. She was drowsy. There were signs of frontal bossing with slight wrist widening, no dentition. She was 13-month-old, sparse hair, tinea infection on the abdomen. So I will just show you her photograph. Have a look at it. I have not, covered her eyes because I wanted you all to just have a look, and I shall then remove it. She was severe malnutrition. All parameters were below the 3rd Z score. She was exclusively breastfed. No complementary feeds at all were started. And she was immunized for age. So this is her photograph at 13 months when she's sitting, when she is much better after the treatment. So that is what I described: sparse hairs, frontal bossing, slightly widened wrist, and severe pallor. But of course, over here, she has been transfused, and therefore you cannot really make out. Now, investigations on admission.
Yeah, Dr. Kundan wants to say something.
Yes.
Ma'am.
Pardon?
Hello.
Yes, tell.
Hello.
Please.
Ma'am, on clinical grounds, it looks like a failure to thrive.
Yes.
With there is a fast breathing is there with no complaints of cough and cold. Then it is mostly failure to thrive because of acidosis. Is chances of acidosis is there because of fast breathing is there. So it can be a case. So I will be thinking for failure to thrive with acidosis. Mostly I will point out towards renal clause like renal tubular acidosis, and this on clinical grounds I think failure to thrive and with acidosis.
Yes. So we'll go on with the investigations. You can further suggest what all you will do to corroborate your this provisional diagnosis which you have made with the presentation and history. So this child on admission had a very low hemoglobin of 5.2 with a total count of 28,000, 52 neutrophils and 40 lymphocytes, with platelets being slightly high with 6,76,000. And these were her parameters of MCV 78.3, MCH 26, MCHC 33, just about okay, but slightly raised RDW. And on the peripheral smear, the RBC mass is reduced with microcytic hyperchromic, normocytic normochromic anemia with increased platelets which were clumped, and there were some target cells. So you would have any comments on this, CBC?
Yeah, ma'am, this points to a chronic anemia and a very severe anemia.
Yes.
Microcytic hypochromic, and RDW is 14.8, slightly raised. But
yes.
in so again, as Dr. Kundan has said, it is pointing maybe pointing to a renal cause because the child also has some signs of rickets.
Yes.
With bossing and
yes.
severe anemia.
Yes.
Ma'am, the PS points towards iron deficiency anemia.
Yes, iron deficiency anemia. So we go ahead. You need any more tests? Any history you would like to ask?
History of urination.
Okay, so there was a urine output of about 4 to 6 ml per hour per 24 hours. Like it was not ml per kg per 24 hours. It was not polyuria, but yes, it would touch 6 sometimes. There was no history of polydipsia as such. And other than that, there was no other urinary complaints so far.
Urine examination?
Urine examination showed just a few pus cells and there were occult blood, but that was in the second admission, not in the first admission. So mostly it was a normal urine with just 0 to 5 pus cells.
Ma'am, history of weaning. What baby is 13 months, so what weaning they have started? That is also very important.
No complementary feed started, and urinary pH was 6. Okay. If that helps you.
Did the ABG, I would like to know the ABG.
Right. So I will tell you the further test that we did. Her retic count was 1%. There was P-Vivax positive. Serum electrolytes were done on admission because she was severely dehydrated. Sodium 120, potassium 5, chlorides 103 milliequivalents per liter. ABG showed severe metabolic acidosis with pH of 7.05, bicarb of just 1.8. So she required plan C management for the dehydration, and she required soda bicarb correction also, because looking at the parameters, it looked like a chronic illness too, because just 3 days of watery diarrhea and this child was in a very serious condition. Any more tests you would like to know?
USG.
Yes, USG. Yes, we did a USG. Also, because as someone really pointed out, it looked like a renal cause and she came in severe dehydration. So on the first day, her urea was 93, creat was 2.3. And the next day we did urea went to 116 and creat was 1.5. Stool showed occult blood, but that time urine was normal. In the second admission, urine showed occult blood. So this is what was her test for the first 2 days, and a USG abdomen was done which showed medical renal disease. She continued to have loose stools for the next 4-5 days, for which we treated her, though the hydration had improved. She persistently had tachypnea. 2 transfusions were given because her HB was 5. And we did a sonography, like I said, was showing a bilateral medical renal disease. For the next 2-3 days or for a week, her urea creat remained very high. And we did a vitamin D3, B12 level, looking at her chronic malnutrition and her poor dietary history. So these were the investigations. It was 18.4, B12 was 382, and serum iron studies were done. Because there was no spleen, it looked like a nutritional anemia, not like a hemolytic anemia. And there was a liver which was palpable 1 centimeter. So the serum iron came high, the TIBC was high, transferrin was normal to low, and her calcium was 9.4, phosphates were 6, alkaline phosphatase was normal. Her total proteins were 6.4, albumin 6. Oh, this must be wrong. Sorry. It must be 4.4 and 2.7. This ratio is wrong, sorry. So proteins total were 6.4, not very low. SGPT, SGOT were okay. We found one July report because they were treating her locally. We found one bilirubin high in July. She came to us in October and her chest X-ray appeared normal. Now, any further thoughts on this case?
Ma'am, was the iron studies done before transfusion?
Yes, yes. All samples are collected before the transfusion.
And retic count was done, ma'am?
Retic is 1% only.
Okay.
Ma'am, blood cultures?
Blood culture, urine culture, negative.
Peripheral smear?
Yes, so I'll show you the peripheral smear. I have given over the answer, I think. Peripheral smear was here actually, which I showed you in the beginning. Mass, RBC mass reduced, microcytic, hypochromic, normocytic, normochromic, with clumped increased platelets and target cells. So like I said, this case appeared to be a case of chronic renal disease, and we had taken an opinion of a pediatric nephrologist who had suggested workup for rickets, which we had done, and both these parameters were low. And strangely, what had happened is when we did her X-ray, there were dense transverse metaphyseal bands seen along the distal ends of radius and ulna. So there was no sign of active rickets in form of cupping, fraying, and splaying. So all these long bones and short bones are showing these dense lines, which would be suggestive of
Buse lines.
Yes. Anything else?
Any history of pica?
No history of pica.
Serum iron has been very high, so it goes against iron deficiency.
Yes, it goes against iron deficiency.
But this opaque lines in the X,
Lead
poisoning.
Yes.
yeah.
Yes. So these are lead lines which were suggestive of lead toxicity, but the PS did not show basophilic stippling, which may not be there, and it is not suggested now. So nowadays, we do not recommend PS for basophilic stippling. We do not recommend examination of hair, nails, skin for lead levels. What is suggested is only blood lead levels, which turned out to be 36.3 microgram per deciliter in this child on that admission. Now, would you have any suggestions, any thoughts, any history?
What is the father's profession? Is he a painter or something?
Yeah.
Okay, so the father was a Ola cab driver. He was a driver, and mother was a housemaker staying at home. What other relevant history would you like to know? She's just 13-month-old with bone showing lead toxicity, which means that it has been there for months or even more than a year. So
Mother blood levels of
yes,
lead.
yes. So now it could be a possibility of in utero transfer of lead, because lead crosses the placenta. So we asked the mother for history of cosmetic use. She did not use. However, she and the child used kajal or the commercial surma, whatever is available. So that was the only thing she applied, which she said, and there was no other history. Okay, so now she was there for a month, and this is what her urea creat remained high. Creat remained high, urea came down slightly. Her VBG on discharge was still showing little low bicarbs. And as I said, we had done a pediatric nephrologist opinion. I will show you in the coming slides. And the treatment was started, but we've not yet reached the diagnosis. So on discharge on 411, urea and creat persistently high. I have just shown you what our, our record showed, that she continued to have till we started oral soda bicarb, and her bicarb continued to be low. So this was her record for almost a month. Even her electrolytes took time and they didn't come up. So I told you her pH was 6. So would you like to narrow down the diagnosis to anything?
Renal tubular acidosis.
Yes. Which type would you say?
The pH is on a lower side, 6.
Just the opposite. The pH is on a higher side.
Yes. Yeah, higher side.
So it is distal RTA.
Yeah.
Okay. And
Right.
her USG had shown normal size kidneys, but with medical renal disease. So the nephrologist said this is probable AKI due to severe dehydration. He said, okay, and we had to treat her distal RTA. We did her urinary electrolytes, which turned out to be a little higher. Potassium was little higher. Urine calcium, the calcium creat ratio in urine appeared to be normal. Her TSH and all appeared to be normal. This we did only for her failure to thrive. So we wanted to rule out any endocrine cause also. And then we went into a little detailed history. So we found out that they stayed in Govandi. They had tap water, BMC tap water. It was a 2-room Pakka house with parent and child only. Mother-child history of kajal application, no cosmetics, no painted toys, no history of pica, no recent painting in the house. We informed the BMC because they were using the BMC water. And yes, we did do the maternal and paternal levels, which I will tell you in the coming slide, because they went on insisting on discharge and they had some, land property, something in the village. They wanted to go, and they had been here for a month and they refused to do any more tests with us, or refused the pediatric nephrologist suggestion for a renal replacement therapy or dialysis, because this child was in chronic CKD because of lead poisoning. But they refused, unfortunately, and the child was sent on oral iron 6 per kg, calcium, vitamin D3, sodamine. Weight gain was slightly there, but not really satisfactory for a 13-14-month-old child. We informed the Indian Institute of Environmental Medicine to find the source and family screening, of course, which we had to do. Once or twice she came in the OPD for follow-up, and just look at her urea and creat, 157, 1.6, refused admission again for many months. And then she came again in May. And here again, she was with us for almost 1.5 months. Again, GI complaints, which is very typical of lead toxicity or high lead levels in children. Though she was not very high of 45 microgram, which warrants chelation therapy. Therefore, chelation therapy was not started. However, penicillamine is not available, it's very difficult. So we had not started. The other thing is to give chelators like calcium, oral iron also helps. And therefore, this time again, she came with vomiting. Her weight was, now she had gained some social milestones. Last admission, there were no social milestones, no smile, no speech, etc. But this time, when she came after about 5 and 3, almost 6-7 months, she had a social smile, sat with support, without support, interacted with mother, spoke by. However, she was again very, very pale. This time there was a liver and spleen. 2 blood transfusions were given, and she continued to have vomiting during the hospital stay. So any thoughts, or should I continue? Because there is nothing much to add from my side, but I will still continue. If you have any suggestions, you could tell me.
Any genetic defect which may
yes. So now Unfortunately, because they didn't have a ration card, and I also work in a government hospital, getting financial aid for any test is extremely difficult. Even getting the paternal and maternal lead levels cost us money, and that is why there was a delay. And they did it only during the hospital visits, OPD visit. They didn't do it when they were admitted in the. Then when they came to OPD, we insisted, "Ki we'll arrange money. Please do your lead levels," and that is what I will share with you now. So father was 59 and mother was 64, and the household water was 3.7, which is normal, less than 5. So that means the parents had very high lead levels, and there is a possibility it was an in utero transfer of lead toxicity. HB was very low, and TLC platelets, as you can see, are on the higher side. This time her blood lead levels had come down, probably because we had given her iron and calcium. It had helped her, and the blood lead levels came out. However, what happens is when the lead deposits in the bone, whenever there is a bone resorption, it continues to release small amounts of lead into the blood. That is how the lead toxicity continues. And probably this child also continued to have some amount of high lead level sometime, but she was already in CKD grade 4 or 5. And therefore, that is what was very paramount for her ill health. And her eGFR was just 14%. She was actually grade 5 CKD. Her pH continued to be high, the urinary pH, and her vitamin D3 didn't improve much, though her B12 improved. Parathormone was 24 and urea creat remained high. So unfortunately, she was a patient of CKD. She was advised renal replacement therapy and renal transplant, which they did not agree to. And again, they took discharge in spite of our further management or sending a whole exome sequence, which we wanted to do. Ferritin was high.
Yeah, I was asking about ferritin level. There was no ferritin level.
Was high. Ferritin was high.
Yeah.
So there is some amount of hemolysis which happens also. This time her USG abdomen worsened. There was altered coarse liver echo texture. So now the liver is involved. So there is liver fibrosis, which is a bad sign in lead toxicity also, with kidneys having bilateral raised cortical echogenicity with loss of corticomedullary junction. Again, this is a sign of distal renal tubular acidosis, which is caused by lead toxicity. So she was a case of lead toxicity. We could not find out the cause. The unfortunate part is that okay, so this time we had sent her to hematologist, who then suggested, because the oral iron hadn't helped her much, the HB was low at 6.6. They suggested to start EPO and do the genetic study, continue with calcium supplements, give active vitamin D3 calcitriol, and again suggested. Now, again, they were adamant that they don't want any investigations and they want to go on request. So again, we were forced to send them away. So she was diagnosed as CKD stage 4, distal RTA, global developmental delay, severe acute malnutrition, severe anemia, vitamin D3 deficiency, this time with AG, no dehydration, and previous lead poisoning, though the levels were normal. Now she went to the village. I just called the father 2 days ago and I came to know she passed away on 31st of August. And he told me we came to the village and we started her on Ayurvedic medicines. Now the problem is we do not know earlier also whether they had given any Ayurvedic medicine, because when when the child was ill, they were following up locally in that area only 3-4 times, they told us. And what treatment they were giving from the local doctor, whether they were doing any parallel therapy, we do not know. So this is the problem. And though they belong to that area of Govandi, and we have informed the Environmental Medicine Institute that area needs to be tested for tap water, because it may not be key the tap water is always having a high lead content. It may be episodic, or the lead pipes may have eroded and they give a high lead content. So that is something to be seen in these areas which are Mumbai based slums, which are here for maybe 50, 60, 70 years now, and with no sort of a redevelopment or anything. And of course, environmental medicine and BMC or the government has to take up this project of studying the lead levels in the tap water of the cities or slums. Plus, the other thing that is, when I was speaking to another pediatrician who is actively involved in environmental medicine, the Indian spices which are sold ready-made, the commercial spices which are sold in the market have a very high lead content, they have found out. So this is one history we may have missed, ki what masala that mother used in her cooking and which brand and whether that should be tested for the lead levels. So these are some of the possibilities. The spices they use, the tap water that they are drinking, they used to often go to the village. So we do not know what water they were drinking, what were the walls over there like, whether it was old paint which was peeling off and perhaps the child, touch and even if the child was touching the mouth with those contaminated hands. So these are some of the histories that we should ask when you have a child who is not responding to oral iron therapy of a good dose, good quality brand and compliance. And of course, this child gave us the clues by way of high creat, high urine, urinary urea and creat, and of course, severe failure to thrive. So here we had some other features of chronic renal disease, but earlier signs maybe we can pick up. And always a wrist widening is not rickets. So better to do an X-ray and see what it is about. So just a short case to share with you all.
Thank you, ma'am.
Thank you.
Thank you for an excellent
Thank you.
case. And we always think about the agent and host in our history taking, but your case also stressed the importance of third component is the environment we should always think of.
Yes.
And team Solapur had rightly cracked this case. And I request now Dr. Abhay Shah sir to have their expert comment.
No. When Dr. Bela madam is there, I think she's also HOD. So
no, sir. I told some more already little theoretical part of lead poisoning.
But I think, as rightly mentioned, there is another triangle, host, but the environmental and the agent, but the environmental factors are often missed. So number one, correct history is very important. Secondly, whenever there is a case of iron deficiency anemia, or in that matter, hypochromic microcytic anemia, then the peripheral smear is very, very important. And now this basophilic stapling is, I think, is a dust catcher finding. We don't use it. But it is important when why iron is not responding to iron therapy, iron deficiency anemia. So there are 2 or 3 things. It is maybe some thalassemia syndrome. It can be an anemia of chronic disease. And the third one is a sideroblastic anemia. And fourth one is a lead poisoning. If you remember this basic 4 or 5 things that we have taught in our postgraduate, undergraduate, I think you have to sort it one by one. And here the history is that now the child was also having a failure to thrive, chronic malnutrition, acidosis, so-called rickets. I think so some chronicity is already there. So there was a renal tubulosis on that, some environmental factors there. One thing that comes in my mind with this anemia, liver, spleen, high ferritin, right? Hemochromatosis. And also in the hemochromatosis also there can be this distributable acidosis because of the iron overload. So I think it goes, but I say it's a wonderful case. At least I would not have diagnosed this, to be very frank.
And also environmental medicine is now, an upcoming branch. We have a chapter, we have an IP chapter on So your environmental toxins play a big role and we are not aware about them.
Yeah.
When I attended the workshop in Pedicon this last Pedicon in Gujarat, I did that workshop for environmental and I was surprised these polished rice or unpolished rice.
Yeah.
I mean, the spices, the water.
Spices, even color paints, toys, the colors over the toys, all this.
So I was surprised that a lot of toxins are being, ingested by us even as adults, which we are not aware.
Exactly.
We should know for our chronic illnesses, chronic symptoms. If you have no diagnosis, please do your toxin levels.
Yeah, exactly.
I want to comment.
One question I would like to ask. What about the siblings of the patients? Whether they had similar illness?
No siblings, sir. This was the only issue.
Only child. Only child. It was there.
Any other family members in the family? Like
no. Only the parents were here. And that is why we tested them after getting money, sir. Here, money is a big issue. Lead
Would
is
there,
not done everywhere.
would a
Yeah.
simple long bone X-ray would have helped?
Yeah, one thing was
parents.
Yes,
X-ray of
we
the
could have done long bone X-ray. We can still do it when they come back from the village. I happened to speak to the father just 2 days ago, and I did tell him, when you return, you please do come and meet us. So we will definitely do the X-ray of the hand or something for the parents also.
Yeah.
And the tap water, which I thought would have come high, surprisingly, it did not come. I mean, with great effort, we mobilized money, because getting parents test and a water, 3 tests, it cost us some time to get the money. Nobody donates, you know. So through the social worker,
but
we
some
had
lead level in the water can be
High water
episodic.
analysis can be done by corporation, I think.
Sir, we must have the government intervention here to do the lead levels as a plan of the government, subsidized as a, you know, project to look at certain areas if they have high lead levels.
I want to comment one.
Yes.
Rickets is a disease of the growing bone. That is nutritional rickets. This
Yes.
child is malnutrition.
Yes.
Is having rickets. So you have to suspect other things.
Sir, the bones did not suggest active rickets.
Growing bone. I am telling madam. Rickets is a growing bone disease. The child is malnutrition and having rickettsial sign. So you have to suspect other things also here.
Yeah.
Yes. Second thing, child having presented with dehydration, with some type of pre-renal failure, pre-renal.
Yes, AKI, yeah.
So that the BUN is high and creatinine is more than 10, ratio is more than 10. So there is a pre-renal factor is also there. Third thing is in chronic renal disease, in anemia doesn't respond to the iron. You have to give the erythropoietin, because erythropoietin leads to the deficiency, leads to the anemia. Erythropoietin is produced in the kidney. And here there is chronic renal failure. So there is no erythropoietin. So this child is not responding to the iron. And third thing, in kidney, there is conversion of active vitamin D. Vitamin D doesn't, this child is not responding to the vitamin D, because child has chronic renal failure. There is no conversion from D2 to D3 here.
Yes.
So the because of chronic renal failure. So this child, you have to give the activated vitamin D, that is calcitrol. Then the child is respond to the treatment.
That is what madam has already said.
Yeah. I'm only analyze the case.
Why EDTA wasn't used for lead poisoning in this case?
No, it didn't warrant chelation. It was 34, na? So the chelation is after 45. And secondly, what sir is saying, na? So Nelson mentions erythrocyte protoporphyrin levels, EP levels, which we could not do. So that is also suggestive of lead toxicity.
Lead poison.
Here there is high phosphate. So you have
phosphates.
You have to in chronic renal failure. In rickets there is high phosphate. You have to suspect the renal rickets. In the case there is phosphate is 6 point above 6, I think.
Above 6.
Yeah. This may be because of chronic renal failure. And what is anion gap? You are not mentioned the anion gap. Anion gap is very important.
Whether parents level are high enough, madam. Whether parents level are high enough to call it as a toxicity. Parents lead level.
Yes, they are above 45. So they warranted chelation. And secondly, toxicity is taken as more than 100.
Yeah,
but there are some patients who have no symptoms in spite of a high lead level. So I have called them back. That is why I'm saying they are very irregular in follow-up. We have to phone and call them as if, you know, it's our responsibility.
You're not calculate the anion gap here.
It was high, so that's why distal RT.
Anion gap.
Anion gap.
Oh, you are not calculating anion gap. What is the anion gap?
It's not mentioned, but
it
was distal RT.
Yeah.
No, sodium level remained very low. There was no reabsorption of sodium happening from the distal tubules. Serum sodium was 120, 125. It came up only up to 130 at the time of discharge.
And your urinary sodium is also high.
Yeah.
66 was shown.
In this child, 2 factors, madam. One is the chronic renal disease, and second is the acute tubular necrosis. There is parenchymal involvement accompanied with the tubular involvement. Because in renal tubular osteogenesis, there is no creat high. RTA, there is urine creat is normal. Here
This
there is
child had
two
renal
factors.
medical disease
Yes,
also.
two
Yes.
factors.
It's a parenchymal
Tubule as
disease.
well as parenchyma also.
It's tubular plus parenchymal, yeah.
Yes, sir.
Yes.
The initial lead levels that were done after blood transfusions or before blood transfusion? Because
After. We
So
didn't
that's why
suspect it in the beginning, no?
that's
Yeah,
why
we
it
did not
could
suspect.
falsely show a low lead level,
Yeah,
maybe
maybe.
because maybe her initial lead levels were very high and required EDT chelation at
So
that
they
time.
were done almost a month later, the lead level, because we gave her to BT, we continued to investigate her because it takes time to mobilize money. So we continued, then we sought a pediatric nephrologist opinion. Then, we analyzed all her ABGs continued to be abnormal, urea creat continued. So then it came out that this is a CKD. And then we did an X-ray test. We usually don't do for everyone. We say, "Arey, vitamin D low aaya hai, give vitamin D3. This is rickets." But then when we did X-ray, that was after 3-4 weeks, and that showed that dense metaphyseal lines. Then the lead level was sent.
No response to iron, no response to D3.
Yes.
Yeah.
It's suggested.
No, and lead levels must be high, madam, because otherwise it would not show in X-ray.
Yes, it has been deposited over months or years, they say.
And as you said, they
but
don't
this
come
was
out
a
easily.
13-month or
Like
so
lead-
in utero is a possibility.
Any metal, if it gets deposited in bone, doesn't come out so easily. It slowly comes out. Yeah.
Excellent case, madam.
Excellent case. Very good case.
I want to say only one thing. In this case, when you start this case with that child having the very less hair and manifestation like rickets, so we have to always suspect vitamin D dependent rickets type 2, where they can have alopecia and ricket-like manifestation. And their child also not responds to vitamin D, and their vitamin D levels may be normal or sometimes low.
Actually. High, sir. High. Vitamin D level is high.
Sometimes I have one
normal or
genetically
high?
proven. Yeah, it can be high, but in India, I thought they may have low, because in my case, which is genetically proven vitamin D dependent ricket type 2, it show me the low vitamin D level actually. So I don't know whether
there is hair loss is more.
Not receiving also vitamin D. In theory, it should be high.
Yes.
Actually, because there is no conversion from active to inactive form, and there is no action on the receptor only.
In type 1 and type 2, there will be high. Yes.
Right.
Yes.
Okay.
But in vitamin D resistance, there is total loss of the hair.
Yeah.
There is no so much alopecia.
Hair loss may be variable. That is again the things. And
there's also loss of teeth.
And
type 2, there's loss of teeth, early falling of teeth.
Yeah,
blue line on
that
gums.
also can be there. And second thing I want to, if you could do, Miss, if you had done the ophthalmic examination, that will also.
So it was normal. It was normal. Fundus was normal. Echo was normal.
Because that may help in other type of RTA also in this case.
The thing is, the parents were so uncooperative, it is as if we are jabarjasti doing the test. They were just failing to understand the gravity that your child has CKD and we need to find out the cause. A 13-month-old having CKD means she was like for renal transplant at that age. And these people, हमको घर जाना है, हमारे गांव में जमीन का ये है, जमीन का, I mean, literally asking them stay back for 2 days.
They are not believing on us.
Now they've lost a child. I just came to know 2 days ago. When I called him, when I was making this case, I said, let me find out a follow-up. And he just told me she died on 31st. I was like, so shocked. Then I said, yeah, she was CKD. And he's saying, hum Ayurvedic dawa kara rahe the. I was like, you are adding fuel to the fire.
But there is common source, madam, here. Because
it could be that
lead
Ayurvedic medicine may be containing the lead and the whole family might
the
also.
mother also used to take Ayurvedic medicine. She's the one who gave the baby the lead, high lead. So it actually required a lot of more investigations, but these people were not willing to stay.
All of them might be consuming these Ayurvedic medicine.
Yes,
Ma'am,
yes. They go
just
there. They go to the local doctor, homeopathic, Ayurvedic,
Yes.
Jadi Puti wala, and all those people.
They
So
give heavy metals.
They're having high metals.
Heavy metals, yes.
Heavy
metals.
ma'am,
metals.
just a query. In spite of such a high levels in parents, they were asymptomatic.
Asymptomatic. Asymptomatic. But now,
What was
like
the hemoglobin?
sir suggested, do their
hemoglobin?
X-ray. I will do their CBC also.
Yeah.
I do not know what is their hemoglobin. What is their hemoglobin? What is their renal parameter, RFT? And
They must be anemic. They must be anemic. They must be
now they
anemic.
must be investigated. So I just told him, "Aap jabhi bhi aoge, please come and meet me in OPD, and we would like to help you further." I have just told that message. Let's see, my residents will follow up with him. They will call him, and that's what we do. We call up our patients to find out ourselves. Kaise ho? Too many days you've not come. So some interesting cases we try to keep a track.
That's really good.
Congratulations, madam. You have given a new insight for anemia. We have only read about all these things, but never tried for that. Yes.
Yes.
Thank you, ma'am.
Thank you,
It was
Dr. Markan, sir, is available?
excellent case, madam, and to very much. Hello.
Yes.
Yeah.
Yeah. Led to very much brainstorming discussion. Any more comments by any seniors, experts, or I think Dr. Ramakan Patil sir and Dr. Pramod Kulkarni sir are not there. Dr. Rajendra Kulkarni sir had just joined, who is MMC observer for the session. Sir, any comments from you, Dr. Kulkarni sir?
He has just left. You can proceed.
Okay. No problem. So I think with this, we would like to conclude today's session with the vote of thanks. Hello.
Yes, we can hear you.
So I would like. Am I audible?
Yeah.
Yeah. So I would like to thank today's guest of honor, Dr. Vasant Kalatkar sir, for graciously accepting the invitation and giving his valuable comments. I would like to thank both the experts, Dr. Abhay Shah sir and Dr. Suhas Kulkarni sir, for giving their valuable comments and contributing for the today's session. I would like to thank Dr. Rajendra Kulkarni sir for being MMC observer for today's session. Heartfelt thanks to Dr. Bela Verma madam and Dr. Trupti Joshi for the excellent cases, really tricky and very interesting cases, and very good discussion. I would like to thank both the teams, Team Darashiv, Dr. Birazdar, Dr. Prasad Dharma and Dr. Makaran Barate, and Team Solapur, Dr. Sheetal Gandhi, Dr. Kundan Chopre and Dr. Mitali Burgaonkar for decoding the cases very well. I would like to thank Dr. Makan Patil sir and Dr. Amol Pawar for their wholehearted support for today's program, and Dr. Pramod Kulkarni sir, who is coordinator for Maha IP Case Challenge and who always takes time out of his busy schedule to coordinate the program well. I would like to thank all the zonal coordinators, Dr. Rajendra Khadke, Dr. Anjali Gokan, Dr. Deepa Firke, Dr. Ravindra Sunavne, and Dr. Naresh Taide sir. Also, I would like to thank Dr. Taide sir for being coordinator with co-moderator with me. Thanks to Dr. Neha Singh for always being there for the technical support, and also Pallavi madam for her timely technical support. And in the end, I would like to thank all the enthusiastic delegates. The Zoom was almost full till the end of the session. So thanks for your patient hearing, and we are waiting for you for the next session, which will be there after 15 days. So thank you so much, everyone. With this, we would conclude. Yes, any comments from everyone?
Thank you.
Thank you, everyone.
So with
Work
this,
is very,
we
very
will conclude
excellent.
today's
Excellent.
session. Thank you so much.